Now that you know the quick reference tools and 3 basic categories of interactions, let's work through a case. This 65-year-old male has had symptomatic COVID for 3 days, and you'd like to prescribe him nirmatrelvir/ritonavir. His current medications include clopidogrel for peripheral arterial disease, or PAD, Diltiazem and lisinopril for hypertension, Saxagliptin for his diabetes, sertraline for depression, and Zolpidem as needed for insomnia. His vitals and labs are as follows. His blood pressure is 130/85, his heart rate is 77 beats per minute, and his glycosylated hemoglobin, or hemoglobin A1C, is 8.5%. So, are there any drug interactions that you're concerned about? Use the IDSA's quick reference guide and the drug interaction checker of your choice to determine what action you'll take. Pause the video for a couple of minutes to review his medications and come back when you're ready. Here's the Liverpool Checker's interaction key. We have potential interactions with clopidogrel, Diltiazem, Saxagliptin, and Zolpidem. Remember, a potential interaction isn't something we want to ignore. We need to look deeper. Let's first consider clopidogrel. The IDSA Quick Reference Guide shows that the effect of clopidogrel is likely to be reduced. The Liverpool DDI confirms this and has a lot of information on it, even suggesting prasugrel as an appropriate antiplatelet alternative in certain cases. But wait, what is the patient taking clopidogrel for? PAD. We would be more concerned if he was taking it within the first 6 weeks after a coronary stent. So you could certainly prescribe an alternative, or you could counsel and continue with therapy based on your judgment of risk. Diltiazem also has a potential interaction. If you click on that, you'll see that co-administration may increase diltiazem concentration. So the concern here is bradycardia and hypotension. The recommendation is to reduce the dose, or you could counsel the patient or caregiver on being aware of symptoms of hypotension, like flushing, edema, and possibly have them monitor blood pressure and heart rate. If these symptoms arise, you would assess the patient's risk and pause the medication if needed. If you pause it during COVID treatment, then resume the dose 3 days after stopping nirmatrelvir/ritonavir. It's time for a brain-buster question. Why do we wait 3 days after stopping nirmatrelvir/ritonavir to resume diltiazem? Pause and think about the answer before moving on. Remember how ritonavir is a strong, irreversible inhibitor of CYP3A4? So we wait 3 days because that's how long it typically takes for ritonavir to mostly stop blocking the metabolism of drugs that are CYP3A4 substrates. This is longer than the half-life of ritonavir, which is approximately 6 hours, and even longer than 5 times the half-life, which is how we usually calculate how long it'll take for a drug to leave the body. 3 days gives the body enough time to make new CYP enzymes. Let's continue. We're not worried about lisinopril because there's no interaction expected. For saxagliptin, the concern is increased activity and the potential for hypoglycemia. The Liverpool DDI checker refers to the Saxagliptin product label, stating that when it's given with a strong CYP3A4 inhibitor like ritonavir, the dose should be 2.5 milligrams. His hemoglobin A1C is 8.5%, which may make you think he's not at risk for hypoglycemia, but the hemoglobin A1C doesn't tell us about the day-to-day fluctuations in blood glucose he may have. Now, I didn't give you the dose, but from a global decision-making perspective, you should consider reducing the dose while administering nirmatrelvir/ritonavir if your patient is taking a higher dose. Or you could have him monitor his blood glucose with a glucometer a few times a day while he's being treated for COVID. We're not worried about sertraline because no interaction is expected. The last one to consider is Zolpidem. This one is interesting because of the pharmacodynamics and pharmacokinetics. You know that the dose of Zolpidem may be increased with his COVID treatment based on the information in the Liverpool DDI checker. So we're worried about the potential for increased sedative effects, especially affecting cognition, balance, risk for falls, and urinary retention. And you probably recall that males over the age of 60 should be taking a lower dose of Zolpidem already because of the reduced clearance and increase in volume of distribution. This is stated in the prescribing information. So let's ask him how often he's taking it. He says as needed, about 3 times a week. This is an opportunity for shared decision-making. We want him to be able to sleep, but we don't want him to fall. So let's make sure we explain our concerns about increased exposure to the drug. I find people easily understand the concept of drugs causing problems when mixed and are often willing to make a change, especially for a short time. Because he takes it only 3 times a week, I'm less concerned about rebound insomnia than if he took it every night and then stopped abruptly. So let's ask him if he can pause it during COVID treatment, or if he absolutely needs it, see if he'll take half a tablet. Since he's not taking the controlled release form, we can split it. It's my preference to also mention that if he takes any over-the-counter nighttime cold medicine, then he shouldn't take Zolpidem. Again, this is because of the additive risk of sedation and falls. If he were taking Zolpidem every night, you may have to have him pause it or reduce the dose. If you pause it during COVID treatment, then tell him he can resume it 3 days after stopping nirmatrelvir-ritonavir. So what's our final decision? Go ahead and prescribe nirmatrelvir-ritonavir, but make sure you counsel him on all of the key issues that we discussed.